When you hear the word arthritis, you probably think it's just one thing, right? But really, it's this huge, complicated puzzle. So today, we're going to crack that code. We're going to look over the shoulder of a radiologist and see how they can take a simple x-ray and just unravel this whole complex story that's hidden inside our bones.
And the scale of this puzzle, it's just staggering. I mean, the American College of Rheumatology recognizes over 90 different types of rheumatic diseases. Yeah, you heard that right? Over 90.
So, that leads to the big question, right? When a doctor's looking at an image, just a simple black and white x-ray of your joints, how in the world do they even begin to tell one of those 90-plus conditions from another? It seems impossible.
Well, here's the secret. They're not trying to memorize all 90 diseases. I mean, who could do that? It's all about pattern recognition. See, radiologists have learned to group all these conditions into just 3 main families, and each family has its own unique signature look.
All right, let's jump into the first family. This is the one you've probably heard of the most, degenerative arthritis. You can just think of this as the wear and tear crew. It's what happens from mechanical breakdown, a lifetime of using our joints.
And the main player here, the big one, is osteoarthritis, or OA for short. When a radiologist looks at an x-ray, OA leaves behind a very specific set of clues. First, the cartilage wears down all unevenly, so the space in the joint narrows, but it's not the same all the way across. Then you get the real poster boy for OA, osteophytes. These are just little bony spurs that grow on the edges. You also see these little cysts right under the cartilage. That's what subchondral means. And the bone itself starts to get harder. Put it all together, that's a classic case of OA.
Okay, so what happens if you take all that regular wear and tear and just crank the dial up to 11? Well, then you get something called a neuropathic joint. This is wild. It happens when someone loses sensation in a limb, maybe from diabetes, so they can't feel an injury, and they just keep walking on it. The result is, well, doctors have a great name for it, osteoarthritis with a vengeance. The joint gets so obliterated, it almost looks like someone surgically cut the bone.
And this brings up a super common, really tricky problem for doctors, especially with diabetic patients. They look at a foot that's a mess and have to ask, is this a Charcot foot? That's the neuropathic kind, or is it a nasty bone infection? And the biggest clue? It's all about location, location, location. Charcot just loves to make the midfoot, the arch, collapse. Infections, on the other hand, they usually pop up at pressure points, think the heel or the ball of the foot, and there's almost always an ulcer on the skin right above it.
All right, let's switch gears to our second family. We've talked about outside damage, right? Wear and tear. Now we're talking about an inside job. This is inflammatory arthritis. And here, the big problem is that the body's own immune system has gone rogue and is attacking the joints.
So the textbook example here is rheumatoid arthritis, or RA, and its pattern on an x-ray is pretty much the exact opposite of OA. It tends to be bilateral and symmetric, meaning it hits both hands in the same spots. The joint space narrows all at once, nice and uniform, and you get these erosions, these little divots right at the edges of the joint. But here's the absolute key detail. You gotta remember this. RA almost always leaves the joints at the very tips of your fingers alone. Those are the DIP joints. Super important clue.
But in medicine, for every rule, there's always an exception, right? So let me introduce you to erosive osteoarthritis. It's inflammatory, just like RA, but get this, it loves to attack the exact joints that RA spares, those fingertip joints, the DIPs. So it's a classic mimic, it can really fool you, but it has one feature that is absolutely unforgettable. And this is where a great buzzword is worth 1,000 pictures. The erosions in this disease are right in the center of the joint, and they create this perfect shape that looks exactly like a seagull in flight. They call it the gull wing sign. If you see that, boom, you know you're looking at erosive OA.
Okay, let's talk about another big inflammatory player, psoriatic arthritis. Let's put it head-to-head with RA. RA, remember, is symmetric and hits the joints closer to your body, the knuckles, the wrists. Psoriatic arthritis is usually asymmetric and hits farther out, in the finger joints. But here's the real kicker, the biggest difference of all. RA just eats away at bone. Psoriatic arthritis, it's a destroyer and a builder. It eats away bone and then builds this new kind of fluffy-looking bone right beside the destruction.
And man, psoriatic arthritis has some of the best visual clues in the business. You get this fuzzy appearance on the bone from all that new bone growth. You can get a sausage digit, where the whole finger just swells up. You might see an ivory phalanx, where an entire finger bone turns stark white and dense. It can even fuse the joints completely solid.
But the most famous one, the buzzword everyone knows for this disease, is the pencil in cup. And it looks exactly like it sounds. The erosion is so bad that one bone gets sharpened down into a point like a pencil, and the bone it connects to gets hollowed out into a little cup. It's a devastating look for sure, but wow, is it specific.
Now, there's a close cousin to psoriatic arthritis called reactive arthritis. The name tells you what it is. It's an arthritis that happens in reaction to an infection somewhere else in your body. On an X-ray, it looks almost identical to psoriatic arthritis. You get both the erosion and the new bone. So what's the telltale difference? Location again. Reactive arthritis almost never hits the hands. It really prefers to go after the feet and the lower body.
And when you're talking to the patient, you're looking for this classic trio of symptoms. You've got urethritis, conjunctivitis, that's inflammation of the eye, and then, of course, the arthritis.
And this leads to one of the most famous and maybe a little bit edgy mnemonics in all of medicine to help doctors remember that triad. It goes, can't see, can't pee, can't climb a tree. Can't see for the conjunctivitis, can't pee for the urethritis, and can't climb a tree for the arthritis. It's memorable, for sure. And hey, it works.
Okay, on to our third and final family. So we've covered wear and tear, and we've covered the immune system attacking itself. This last group is different. It's all about something depositing inside the joints that just shouldn't be there. Let's meet the metabolic arthritis family, or as I like to call them, the crystal culprits.
The most famous one here, of course, is gout. This is all caused by uric acid crystals. The classic story is a man over 40 who wakes up with a big toe that is just screaming in pain. But what's super interesting on the X-ray is that gout is actually kind of polite, to the joint space anyway, at least at first. It tends to leave the cartilage alone and instead creates these really sharp, punched-out looking holes right next to the joint.
And that leads to its own fantastic buzzword. As the bone is getting eaten away, the body tries to wall off those nasty uric acid crystals. So it builds up this hard, bony rim. And that rim creates what looks like an overhanging edge. You see that? It's a dead giveaway for gout.
The other major crystal disease is CPPD. That's a mouthful. It stands for calcium pyrophosphate deposition disease. Its #1 calling card is something called chondrocalcinosis. You can actually see a thin white line of calcium right in the cartilage on the X-ray. It's amazing. But its most powerful clue isn't a word, it's a phrase. Degenerative change in an uncommon joint. What does that mean? It means if you see what looks like really bad osteoarthritis, but it's in a weird place, like the wrist or the shoulder or behind the kneecap, you gotta be thinking CPPD.
Okay, so we've gone through the 3 big families, right? We've seen their key features, all their buzzwords. So how does a radiologist actually put it all together in the real world to crack a case? Well, it's not magic. It all comes down to a really simple, logical flowchart.
And believe it or not, it all starts with just one question. One simple question. When you look at that X-ray, you ask yourself, are there erosions, or is the joint space narrowing symmetric and uniform? That's it. That is the first and the most important question you have to ask.
And the answer to that one question immediately sends you down one of 2 paths. If you answer, yes, I see erosions or symmetric narrowing, then boom, you're in the inflammatory family. Your very next question is just, okay, is there any new bone being built? But if the answer is no, this looks like asymmetric wear and tear, then you know you're in either the degenerative or metabolic camp. And your next questions are things like, is this a weird spot for osteoarthritis, or is this destruction just completely over the top? And just like that, this giant puzzle with more than 90 pieces, it just becomes a simple series of choices. It shows you that it's not about memorizing everything. It's about knowing how to think and asking the right questions.